All right, good morning, everyone. Today is the best lecture. It's the lecture that you've all been waiting for through nursing school. It is the urinary system. Absolutely the best thing to talk about today. So I'm going to talk to you about the kidneys, urinary elimination specifically. Can anybody tell me what percentage of freshly oxygenated blood goes to the kidney every time your heart pumps? Does anybody know? Can anybody take a guess? 82, 50. Okay. Some good guesses. 60. You guys are jumping pretty high. The actual answer is about 20%. Every time your heart pumps, 20% of that blood goes right to the kidney. It deals with filtering and it deals with oxygenation, but it is there every time your heart pumps. 20% of that blood goes there. So I want you to start thinking about how much your body needs these kidneys to work appropriately, because every system is affected by the kidney's ability to filter out toxins. There are several slides on here that talk about review. This is anatomy and physiology review. I'll mention a few things in each one of them, but in general, you have your kidneys, you have your ureters, which actually just bring all that urine down into the bladder, which is there, and your urethra, which allows it to leave the body. You have your female and male urinary tracts. Now, when you're looking at kidneys and when you're assessing your patient in general, you need to know how to assess every system. And this is no different. You need to be able to visualize on a patient. You know, are you looking for redness? What does the urethra look like? What does the tissue around the urethra look like? Is the bladder distended? Does their belly look like it's larger? Are they saying it's a little bit bigger than normal, or they can't go to the bathroom? They can't urinate, micturate, if you will, on this one. You need to be able to palpate, be able to feel on that belly. Does it feel like it's hard just where that is or versus the whole abdomen? You need to be able to differentiate between that. Also, you need to be able to check the kidneys. They're in the back, so pushing on the front doesn't teach much. If you remember, I showed you guys how to tap on those kidneys before on assessment day. That's what you're looking for. We're seeing if there's any sort of inflammation, because by tapping on it, if it's inflamed, they'll tell you pretty quick if it hurts. All right, again, review. What does the kidneys do? They maintain composition, body fluid volumes. They help filter and excrete blood, but they also do a couple other things. They produce erythropoietin, renin, and activate vitamin D3. Can you tell me what erythropoietin does? Or renin or D3? Erythropoietin does make red blood cells, helps make with red blood cell formation. Renin deals with vasoconstriction, yes. Yes, specifically in the bone marrow, yes. And what about D3? Active D3 specifically. Calcium absorption, yes. So you do need to know that. Kidneys deal with that. Erythropoietin, we've got red blood cell formation, blood pressure control with the RAS system. Yes, you need to know the RAS system. If you just like, there's so many things in science that you take for granted. When you get to this place, you need to know the RAS system and how it goes through, because we'll talk about it later in this lecture. It also deals with absorption of calcium, helps make sure that we have everything that we need or get rid of. And we excrete waste products in urine. Nephrons use filtration because that's all the kidneys are, a big filter with active transport to allow us to bring things back in that we may have accidentally lost. Ureters transport urine to the bladder. Again, there's one-way valves in there as well to make sure that as we start getting rid of this urine, that it doesn't accidentally come back up. We have valves that stop that, especially when we get to the end of the ureter, so it doesn't go back up to the kidneys. Whole bunch of anatomy here. But remember this, when we're talking about the kidney, the purpose is to filter blood, reabsorb that filtrate that should not have been filtered, and use hormones to help control electrolyte and fluid levels to make sure that we are at the proper level at all times. So if these kidneys aren't working, both of them, then we have some major problems when we talk about these dilutions and we talk about all these toxins that can be in our body very quickly. Things like the liver likes to make things water soluble, so it can get to the kidneys and leave the body very quickly. But even if we make something water soluble and the kidneys don't respond to it, it's still in our system after a while. And toxins can break back down into things that are harmful to us. So we have to make sure that our kidneys are very well taken care of. Anatomy question, but do you know how many nephrons we have in each kidney? Loads, 1 million, a lot. Well, you're absolutely right. It's not a billion, but it is 1 million approximately per nephron. But that depends on your age, which I'll talk to you about in just a minute. But these kidneys are extremely efficient. You have to actually lose 50% of your nephrons to see a decrease in urinary output. So you could lose a whole kidney and still have a normal urinary output of that 30 mils per hour baseline. When we talk about kidneys, we talk about the nephrons. We need to see a minimum of 50 to 60 mils per hour of urine to really show us that there's a good, healthy amount of output. Yes, I said 30 earlier, but 30 is your baseline. Like if you're below 30 mils per hour, you're not getting enough tissue perfusion to those kidneys. There's going to be some damage happening or something's occurring. We like 50 to 60 mils per hour. Anything could be caused. You could have dehydration. They could be drinking caffeine, alcohol. We have medications that can do that due to side effects or specifically changing that by the medications. And diseases in general. A lot of them can affect this in a way that causes these numbers to change. This is showing you a general idea of the nephron. This is what I'm talking about. If we remember for the anatomy and physiology, we have the afferent arteriole. We have the blood coming in here to that Bowman's capsule where filtration begins to occur. And this is literally just a filter. Things have only certain things should be able to fit through this filter. It's only so big. So if you have damage to this filter, what's in that Bowman's capsule, what happens is as this starts opening up, you start opening things like blood can get into there. You can have proteins getting into there because they're much larger than the normal things that should be going into there, like water and drug metabolites. So that's when you start seeing things. When tissue starts to become damaged, you start seeing things in the urine that shouldn't be there, which is a very, very good indicator of what telling us how healthy a person is or how diseased and damaged the kidney is. Again, some more review. Urine is acidic. It is very acidic when we deal with things. So remember, when you're taking care of these types of patients and thinking about it, what would you want to do to take care of somebody who's leaking urine or can't control their urinary output? Keep them clean, keep them dry. Yes, absolutely. Keep them from to prevent emaciation. Yes, prevent skin breakdown, skin barriers. Clean them as soon as possible. Don't let them sit in urine. Don't let them sit in stool. If they can't control it, you need to help them. You need to take care of them because you're going to have a major problem with skin breakdown and they're going to start having a higher risk of infections with that skin breakdown. So help prevent that. Absolutely. Clean that patient. And when you're cleaning them, you can assess them to see if there's any further skin breakdown. Tubular secretion. This is active transport. When something gets put into the tubules, 99% of what gets put into the nephron gets taken back out of the nephrons because we lose things in there and our body has hormone control to help make sure we bring things back in, whether that be water, whether that be sodium, calcium, potassium, whatever we're dealing with and we lose into there, our body pulls it back in if we need it. And again, that's based on hormonal control. Your antidiuretic hormone, aldosterone effects are seen at tubular secretion, depending on where you are in the nephron. We use both active and passive transport for this, though. We have salt levels outside in the kidneys that help pull water back in, and we filter using that. So remember, when you guys are dealing with these types of situations, with a kidney, what's going on is we have all these different hormones that have to be working in sync to keep homeostasis, or we start losing water and things like electrolytes very, very easily, and we can have problems with that. The bladder. The bladder is thick. It's 3 layers of muscle, okay, the detrusor muscle. The bladder holds the urine. In that urine, or excuse me, in that bladder, nothing should be reabsorbed into the body. it's done. It's gone through all the filtering. If you think about it, the filter is that nephron. We've got everything in the collecting ducts. Now we're in the bladder. That means everything that should have been pulled out is done. It's out. It sits in this 3 layers of muscle so the body doesn't accidentally reabsorb anything until you're ready to actually empty everything. You have an internal sphincter, which begins to, we have baroreceptors in the actual bladder that tells us as we begin to expand out. That internal sphincter, when you're ready to, you have control enough to be able to say, hey, I want to release this now. And then it goes out to your urethra and your urine is released. That's the point of the bladder, is just to hold it until you're ready. But it only holds so long. It only holds so long. Again, this is the idea of the epithelium, but this is the idea of the bladder. It can extend out. There are actually little folds here to stop urine from going back up to the ureters as things begin to expand and this bladder fills. The urethra. Women, I'm just going to tell you, you guys probably hate your urethra because of what's going on, as you can see on here. They are extremely small. Women have a very high risk of UTIs just because of how short their urethra is. Men tend to have one that's much larger, at least around approximately 20 centimeters long, but that is actually kind of a deterrent to bacteria. The longer it goes up there, the more our tissues can help stop UTIs from forming. Women only have a 3 to 4 centimeter urethra, which means they're more prone to UTIs and things getting up into that bladder. So remember that when you talk about specifically women, they do have a higher risk of UTIs compared to men. Micturition, your favorite word of the day. This is the fun, fancy word for urination or voiding. Micturition. It's a process of emptying the bladder. The bladder gets to between 200 and 450 mils of urine, but it can hold up to a liter, depending on how long you've been practicing with it. This is not a nursing bladder, just so you know. This 200 to 450 mils, if you can empty your bladder at that point, good. Is it going to happen where you can't? You're going to have to learn to hold it? Absolutely. But you shouldn't if you can. As soon as you start feeling that, if you've got a moment, empty that bladder. You don't want to increase that risk of UTIs, damage any of the sphincters. Empty it as you feel it. Those stretch receptors start telling you something for a reason. You'll begin to contract when you feel that, those muscle contractions. You'll push that detrusor. You'll have the internal sphincter relax, and then it goes into the posterior urethra. You have muscle contractions again, diaphragm lowers again, all these things pushing on that bladder to allow that urine to flow and micturition to occur. Now, box 28-2 and on page 718. It's on there. So page 718. I updated this for your new one. Make sure you look at this. This is just a whole bunch of terms dealing with urination or micturition. On here, you have anuria, dysuria, enuresis, hematuria, nephrotoxic, and there's several other words on there you just need to understand as you start going through this. But anuria, A means without, uria, without urine. Dys, meaning difficult or painful, dysuria. Aneurysis, involuntary loss of urine. Hematuria, blood, hema, in the urine. That's how this works. And nephrotoxic, something that damages the kidneys. An NSAID is considered by definition of what it is, nephrotoxic, just so you know. So those types of things are what you may see as you're talking to think about it. So you have to start thinking about your patient who's got currently, who's on dialysis, both their kidneys are working, and somebody talks about giving them an NSAID. Would you worry about giving somebody an NSAID at that point? Maybe, yes, absolutely. Something to think about is like, especially if they're, they're getting to the end stages of renal disease where their kidneys aren't working, and you just know that, while you don't necessarily know, remember what Professor Arnapol said about kidney damaging. You can remember NSAIDs in general damage the kidneys by definition of what they do, because they specifically stop a certain thing called prostaglandins from being able to be created by the kidneys, which damage them. So again, that's what I'm talking about, nephrotoxicity. Things can harm the kidneys. Other terms that you can look about in this, you have nocturia, which means, again, nocture, night, uria, increased frequency after bedtime. which happens a lot when somebody who's got like edema in the lower extremities, they lay down to sleep and the fluid comes back to the kidneys and all of a sudden they have to go to the bathroom more. Oliguria specifically deals with less than 400 mils of urine in 24 hours. And while I said anuria is an absence of urine, the textbook definition for you to know is less than 100 mils in 24 hours. Which pretty much means almost none. There are people who can make absolutely no urine, depending on how bad those kidneys are and how scarred up they are. But those terms are, again, in that box for you to know. Hey, what was the minimum amount that you absolutely need a kidney to be able to have for urine, for mils per hour? 30. We like 50 to 60. 30 is the bare minimum. And you need to know how to calculate how much urine output there is per hour using that. 50 is what we like it to be. The bare minimum is 30. We want to ensure kidney perfusion and renal blood flow. So what's normal? We like it 50 to 60 mils per hour, 1,500 mils per day. Our bare minimum is 30 mils per hour. That is the only, if we are below that, we do not see proper kidney perfusion. This can fluctuate a liter or two, depending on factors. Again, how much are you drinking? Well, are you taking any medications that can affect that? How old are you? Because at a certain point, you start seeing a decrease in kidney function just based on age. Frequent urination is not the only sign. You can also see decrease in urination. You can see increased concentrations. All of a sudden they say their smell or their urine smells really strong for some reason, or it looks extremely white, extremely clear, and they're urinating a lot. They don't quite understand it. Again, assess. Tell me about your urination. How much, when was the last time you urinated? What did it look like? What did it smell like? Did you see any blood in it? Any odd colors related to it? Assess your patient. Find out what you can. Do you know what it means? You may not right away, but assess it. Get the information because we can find that out later. Specific gravity, 1.002 to 1.030. Know it forever, okay? When you start working in the hospital, you will have, of course, those little sides on the charts to remind you, but this is a very important lab to know. It tells you how dissolved the urine is, how many solutes are in there. If the number is lower, it's more dilute. 1.002, I'd expect it, light yellow, very see-through, not much there. Okay, they've been drinking a lot of water. They've been doing, their gallon or two of water a day. I see something at 1.030 or above. This stuff's dark. Okay, we get to that point. We're not talking blood, but we're talking, you get that. If you ever haven't had enough to drink one day and you go to urinate, micturate, everything kind of gets that like darker tone. You get a stronger smell to it. That's what we're talking about. That is that higher specific gravity. Your body still gets rid of solutes. It still does that. So it absorbs less water because there's less water for your body to have. So it'll take that water back and get you this really strong, potent, high specific gravity. So it's something to think about when you start assessing your patients, looking at those Foleys and seeing how their urine looks. Lots of different things affect your ability to micturate. A lot of them. You have developmental considerations. For those of you who have children, how often does a newborn micturate? For those of you who have taken care of children. Every hour or two, 8 times an hour. Hour or two often. Yes, absolutely. I'm going to tell you right now, technically on average, the newborns pee approximately 25 times a day. You may not catch that diaper every 25 times. There might be a little bit here, a little bit there, but approximately 25 times or more a day because they do not concentrate urine well. Their kidneys are not fully formed. The nephrons are not working at peak capacity. The hormones are not where they need to be. So while we're dealing with that, you will normally see a lot of wet diapers on a newborn. You'll see a lot of urine starting to come out, and it may be very clear. Again, they're not good at concentrating urine well. Personal hygiene. As they get older, people's bladder elasticity begins to decrease, especially if they began to hold it for some career of some kind where they constantly can't go to the bathroom. Their bladder elasticity begins to scar up and they can't go as far. So that increases the frequency of micturition. Socioculture. Sometimes if you need to assist somebody to the bathroom, let's say we have an older gentleman who's you're taking care of, and they need assistance to the bathroom, but they don't want you because you're female. They want a male to help them. Well, we're in nursing, and it's very difficult sometimes to find a male on the floor. We are still the minority. So that patient may choose to hold it because they want to wait for a male to help them. They don't want a female to help them with the restroom. You can educate them and educate them. Sometimes you can get them to do it, sometimes not. But socioculture-wise, that patient wants a male to help them. So that can affect them. Hydration and nutrition. Again, are they eating and are they drinking enough? Psychological variables. There are disorders that are psychiatric in nature that can increase or decrease that. Muscle tone. Are they paralyzed? Do they have paraplegia? What is causing any problems? What diseases do they have? Have they been under anesthesia or surgeries of some kind that have decreased their ability to actually void? Any medication side effects? Medications themselves can increase or decrease urine formation. Big things to think about with diet: caffeine, chocolate, alcohol, spicy foods, all can increase micturition. Anxiety. You talked about, we talked a little bit about adrenergics and things. Anxiety, for just a moment, what do you think anxiety does to your ability to void? If you're anxious, it slows it down and reduces it. Again, think fight or flight, okay? If you're freaking out, fight the bear, eyes are open, what's going on? Everything's slowed down. We want everything's going to be off to our external extremities so we can respond to it. So if we're anxious, it decreases our ability to void. Now, you may have some other loss of control and have a little bit of dribble when you're fighting that bear, but we're talking about the ability to void and the ability to make urine. Our blood flow releases from our kidneys as much, so we can actually respond to that actual bear situation. Pathological. If the kidneys are inflamed, infected, off, damaged, trauma, something's wrong with it. Now we have an issue with the ability to actually do something and make urine. So infections, tissues aren't responding appropriately. Kidney stones, kidneys could be fine except there's a big blockage in the way. And now we have to deal with other problems. Hypertrophy of the prostate. Everything works. The kidney goes down to the bladder. We go right where we need to be. And then we can't get it past either the ureter or the actual bladder because there's stones in the way. With the hypertrophy of the male, we're dealing with everything working, like I was saying, but when we get to go out the actual urethra, there's an inflammation, there's a blockage in the way, making it where we can't do anything. Mobility problems. Again, maybe they can't get to that, and maybe they can't actually get to the bathroom. And now they have an issue getting there, and they just urinate on themselves. And then they have issues like skin breakdown. Decreased blood flow through glomeruli. Again, infections, stones, scar tissue, age, neurologics, communication problems, telling us specifically they need to go to the bathroom. Maybe we can't, maybe they don't speak anymore, or they're in a coma and they just go and we don't check them often enough. We have a problem. Or altered cognition. Maybe they don't recognize that they have the need to go. If you don't know this system, you're going to have a hard time when you get into your antihypertensives. You need to understand the RAS system, renin-angiotensin aldosterone system, or on this slide, it's called the pathway. But that's what we're talking about here. We deal with the regulation of blood pressure, sodium levels, potassium levels, hydrogen, dealing specifically with acidity, in the blood. This is how we control it. So have an idea of how this works, okay? Fluid and sodium control. We need this to be controlled. From here on, I want you guys to start thinking about electrolytes in small amounts. The beginning of next semester, we get into a fluid and electrolytes exam and really get into it. But one of the big ones is sodium. Wherever sodium goes, water follows. So wherever there's a larger amount of sodium, that's where the water goes. So if we have hypertension and we think it's more related to, volume levels, we'll get stuff to make sure that salt level goes down, which takes the water with it, which on definition decreases the blood pressure. I know you guys have talked about this when you talked about antihypertensives, but that's how you start thinking about these. Lifespan, we talked a little bit, but effects of aging. Nocturia. What was nocturia? Fun word. I already said it. What is it? Pee at night. Yes. Urination at night. Absolutely. They don't have to have edema. They just could be resting and all the blood, all the fluid in their body kind of slowly starts filtering to the kidneys, and the kidneys make more urine, meaning they have to go at night. Yes. Increased frequency in general. Again, we talked about the idea the bladder doesn't expand as much, and so urine that is made kind of pushes more on those baroreceptors. Retention and stasis. Inability to fully empty the bladder, especially in men with BPH. That hypertrophy of the prostate makes it difficult to fully empty. And by having that issue, we keep urine left over, and constant static urine and retention urine has an increased risk of infection. Voluntary control affected by physical problems. Again, they feel like they need to go, but they can't make it to the bathroom. They can't walk there fast enough until they have an accident and micturate or urinate on themselves. These are just some numbers. These are some ideas. 8 to 10 wet diapers a day, 15. And do not memorize these. You are not in pediatrics right now, but this is to kind of show you the changes in lifespan considerations. Infants have no voluntary control yet, so they go multiple times a day. Children need toilet training. They do, only once their neuromuscular system gets to that point. I know you're going to spend time in this with pediatrics, but think about this. There are plenty of children who become potty trained at the age of 1, maybe 2. Some people need till 4 to get that. It has to deal with neuromuscular systems and training. You can't train someone to do something if their neuromuscular ability isn't there yet. So some people take a little while to get through that. Adequate communication skills when we're talking with children. They need to be able to tell us they need to go so we can actually put them in there, into the bathroom. And then you've got enuresis and nocturnal enuresis. Enuresis is a fun word dealing with children dealing with a loss of gained control. So what they normally have the ability to go to the bathroom, and then they have an accident in the middle of the night. Enuresis, or during the daytime. Nocturnal enuresis would be in the middle of the night. A lot of times at night, that's due to like a nightmare, a night terror, something like that. Again, don't get lost on this. You'll deal a lot with this in pediatrics, just some terminology and some things to think about. Now, older adults, kidney functions. You don't have to tell me, but for those of you over the age of 40, I have some amazing news for you in this, okay? At the age of 40, and for the rest of your life, you lose 1% of your kidney function forever, meaning every decade you lose 10% of the ability to void. Every single year, just so you know. And that has nothing to do with what else you do to your kidneys. If you've ever drank it heavily, you've damaged your nephrons. You ever got hit hard and actually, maybe you've accidentally micturated some blood because somebody hit you in the kidney with a baseball, or you've accidentally hit yourself or fallen and you had some damage. You've done some damage to the kidneys, and some of the nephrons are dead and they've scarred over. Guys, I know you're all excited about this number. I am so excited too, because I heard this and I said, oh, goody. Another thing to look forward to 40. But please remember that you need to lose at least 50% of your kidney function, of your nephrons, before you see a decrease in urinary output. So, if nothing's wrong with your kidneys and you start at 40, you've got till 90 to see something change. So 50% of nephrons. All right, alterations, things that can alter your ability to urinate. You've got congenital, born with like tubes that are going the wrong way, tract abnormalities. Polycystic kidneys that can change things. Again, when we get to disease processes, we'll talk about some of these things. Urinary calculi. Calculi is the fun word for stones. So we have stones in the way of the urine. That's what we're talking about. So sometimes they'll just pass. For those of you who have the kidney stones, you probably know that they're not fun to pass, and hopefully they're not big enough. Hopefully they're not big enough to cause a problem where you have to have surgery or a treatment that they pretty much, there's a treatment that they can do for some of these larger stones where they put sound waves and pretty much punch you in the side with sound waves. It doesn't feel good. It's not the best thing in the world. It does bruise and it's extremely painful, but it does help destroy those kidney stones. Lithotripsy. I couldn't remember the word of it. But urinary calculi, hypertension. Remember how I talked about this is a filter. Okay, this thing needs to stay like this. If you've got high blood pressure, we talk about this. I'm sure you've all been like, oh, you may have, not all of you, but some of you may have been told that you have high blood pressure, but all of you are constantly screened for blood pressure. If you have hypertension and you feel like, oh, I'm doing okay, I'm not having any problems, I don't really need to take my hypertension medications, remember you have a filter. And as blood pressure hits, this gets damaged and begins opening. And that filter can allow proteins in, blood in that shouldn't be allowed in there, because if it is, we can't reabsorb it. Again, how you start having metabolites, blood, things in your protein in your urine that shouldn't be there. So make sure, it's a big reason that we educate patients about hypertension meds, because that's the first big organ that's damaged, is the kidneys. Diabetes, dealing with blood sugar levels. And again, these levels, we're talking about nephrons here. So if we have all this sugar likes to leave to the urine if it can, and the filter's actually damaged enough. Gout, connective issues, system infections can cause issues as well. Other things, UTIs. Which gender is at higher risk of UTIs? You guys were fast on that one. It's like, yes, females, absolutely. Sexually active females have the highest risk of UTIs. Again, nothing different. You can do everything correctly. However, you have a shorter urethra. So by definition, you have a higher risk of UTIs. Urinary retention, again, inability to void. We keep things. You have urinary stasis, increases that risk. Incontinence. Here are some terms to know. Stress incontinence. See all these fun words? I'm not going to read them to you. I'm going to give you some examples to help you think about it. Stress. Laughing or sneezing is a stress, and then causing a urine leakage, that's stress incontinence. Urge incontinence. A sudden need where you're walking around, all of a sudden you have to go. Your bladder just becomes overactive. You have just sudden urge. Mixed. DM on the last slide. Yeah, thank you for answering that, Raven. Mixed. So this is a combination. You can have urge and stress. Yes, the wonderful thing about incontinence is you can have multiple versions at once. At least you know what happens. Overflow, where your bladder just doesn't quite hold everything because you have a lot there. This can happen with fecal impaction, where they can't go to the bathroom, or they have a lot of stool left behind, because, you know, the GI system has to go after the urinary system, cause blockages. It can do that. Enlarged prostate, making it difficult to fully empty. And of course, neurologic disorders, having a difficult time controlling everything. You've got functional, inability to reach the bathroom. They can normally control it, but they have a disability or obstacle, or just difficulty in time in general getting there, and then they have an incontinent episode because they felt they could control it, but they couldn't get to the bathroom fast enough. Reflex incontinence, emptying of the bladder without sensation. This deals with, they no longer have sensation there. Could be paraplegia, could be from pelvic surgery, radiation damage, but everything, the bladder fills up and has baroreceptors appropriately, but you no longer sense it. So it just, when it gets full, it just empties itself. So that would be more of a reflex. And then total is it's unpredictable. You have no control. You may have some sensation, but for the most part, you've lost the ability to completely control how your urine is lost. And then you have diversions and urostomy, ways of actually stopping urine from going out the urethra. You have man-made tubes to allow it to empty out appropriately, which we will talk about today. Caffeine, alcohol. What do those two things do to your urine output? What do you think? Increase. Those are the easy ones, okay? Those are the good ones. Think about. You drink a soda, you have a Coke, or you drink, a scotch, or you have a beer, and all of a sudden you're like, man, I've got to go to the restroom all of a sudden, and you go. That's the idea. That's what those things do, is they increase urinary output. What do you think salt does? High salt. I've already told you a little bit. Yes, decrease. It decreases it because we have more salt in the vessels, which means the urine that was normally there, we pull more water back in. So we have less of that urinary output. Dehydration, what does that do? It decreases it. Why do you think dehydration causes us to hold urine or to decrease urinary output? Yes, absolutely. We're storing it. We are dehydrated. Our body recognizes it. As long as our hormones are responding appropriately, we will pull everything in, all the water that we can, we will hold it. And we will tell you we need to drink more, and we will hold everything that we can. Another reason that when you're dehydrated, don't drink your urine. We've gotten rid of everything that we can at that point. Don't do that. It's not a survival tactic. There are things that you can do, but we are not in a survival class. Don't drink your urine. Dehydration we talked about. Surgery and anesthesia a little bit more. This actually has several things. So this decreases our urinary output. Does anybody know why surgery and or anesthesia would decrease our urinary output? CNS depressed, relaxes. Yes, stalls the CNS. What happens to your blood pressure when you're under anesthesia in general? It drops. So if we have a decrease in blood pressure, what happens to renal perfusion? It goes down. And if you don't have the blood perfusion to the kidneys as well, we'd expect to see a decrease in urinary output. Does that make sense? You see connect the dots with that? Makes sense. You think about it. Blood pressure goes down, which means less perfusion to the kidneys or glomerular filtration rate. Make sure you know what a glomerulus is, but if you think that glomerulus and Bowman's capsule and we're filtering, a lab that you can check is called a glomerular filtration rate, because that's how much filter is going through there. And if we decrease that, we'd see less urinary output. Absolutely. Good, good, good. Immobility, inability to ask for assistance, and cognitive changes. Again, psychiatric disorders, maybe not knowing or not being able to sense that they have a need to go to the restroom. Clicker check. Female states, I'm so distressed, it seems like every time I laugh hard, I wet myself. What condition is this? Oh, come on. You guys knew this one. Good, good. Stress incontinence. Nursing process. Assess your patient. Okay, that includes the data. Voiding patterns, habits, past history. How do you ask someone the last time they went to the restroom? Just ask, okay, when was the last time you were in the restroom? Good. Be careful. You are absolutely right. Be sensitive when you're talking about any sort of genitourinary. Urine's easy. Just because I say, hey, when was the last time you went to the restroom? Or when was the last time you peed? Sometimes you have to, be a little more blunt with some of the words. Don't use the word Micturition unless you're talking to me or a urologist. But you can say, when was the last time you urinated? They may not understand. You may have to go down and say, okay, when was the last time you peed? That's okay. But make sure that you are careful. Yes, and when was the last time you urinated? Be careful with your questions, because genitourinary is embarrassing to many, many, many people. Yes, you're going to find that 87-year-old nurse who's going to show you and say, oh, yeah, you want to take a look? Here you go. Or, yeah, I went to the bathroom here, and I did it this many times. This is the color. It smelled like potatoes, and it had this issue. They're going to tell you stuff if they know that. Other people are going to say, they're not going to give you anything unless you ask them, because they're extremely sensitive to genitourinary, because that's the culture that we're in. You need to be sensitive to that and ask the questions. If they prefer not to answer, you need to be able to tell them, I just need to make sure that, you know, you're going to the bathroom appropriately, or you're not bleeding. Is everything okay? Get what you can, try and get as much information as you can, but sometimes it's difficult. So you need to assess appropriately. And be very caring and sensitive with your questions. Physical examination, we've talked about assessment with this. Correlation with other results. So we haven't talked about acute renal failure. We haven't talked about much, but we have talked about, if you think critically, alcohol. So if I had a patient come in who fell, broke their arm in the ER, and they've been drinking with their buddies all night. They come in and they're like, man, I have to pee so much. I'm not used to this. What are some questions you might want to ask? Have you had any alcohol? How much alcohol? Good. What have you been drinking and how much? Absolutely. Anything else? When was your last drink? Good. How much alcohol? When did you drink? How much have you had to drink? Oh, I've had, you know, a 6-pack 3 times over in the last, 3 hours. Any pain? 2 beers? How many drinks? Yes, absolutely. And you're getting good information. How often do you normally urinate per day? Good. You need to know. You need to understand that kind of stuff. Have you had any water? That's a really good one, Aaron. So you've had beer. How much water have you had? Because all this alcohol is going to go out and you're going to be dehydrated. So absolutely. Good, good, good. Would I expect to see urinary output elevated after somebody drinks like that? That's how you critically think this. I have this situation, and here's what I see. Would I expect this, or is this abnormal? Now, let's say I had the exact same thing, but the patient has been able, says that he's drank a whole bunch. 42-year-old comes in, he's had a whole bunch. He's about to get married in the morning. He hasn't peed in 2 days. Are you worried? Says his belly's been getting bigger, but he's like, it's all the beer today. You worried? Yeah, I'm worried. How many mils per hour are you supposed to make? Minimum 30, absolute bare minimum. How much did I say your bladder can hold? And the slide talks about 400 to 500. It stretches of 1,000. 200 to 450 is what your slide says is where we like to go, and we start feeling things at 150 mils. Actually, you start feeling that receptors going off. But your thing can expand. Your bladder can expand and hold some. So we're talking bare minimum of 30. We're talking 2 days of no urine, 24 hours a day. We've got a lot of urine, and this guy's drinking, so he's making a lot more than 30. When you get to 1,000 mils, you're worried about that bladder rupturing. So assess your patient. We may have to get a bladder scan. Get in here and see what's going on with your patient. Good. Yeah, we can. Yeah, Janie, we straight cath them depending on what's on there, depending on what orders we have. But we'll talk about straight cathing. The idea there is if you have urine in there and it's not coming out, we may have multiple issues, because he's also telling me that he may not have to feel the need to go after 2 days. So there could be some problems occurring. All right, assess your problems. How long has it been there? This is a great old thing to think about. When you find a problem, find out about it. How long has it been there? How severe is it? We do it with pain all the time, 0 to 10. But severe, do you have any pain with it? How severe is the issue? What caused it? Did you do something and it makes it worse? My best piece of medical advice to give everybody: does it hurt when you do that? Don't do that. But it's one of those things you think about. Does it hurt when you extend your arm out? Okay, let's rest that arm. If you think about it, you take care of those patients. You say, okay, I'm going to take care of, now that we know it does that when you hurt, or it hurts when you do that, let's not do that while we figure out what's going on. See what the patient thinks. Oh, I've always had this problem. Or I started this a few weeks ago. I haven't really thought anything out of it. I was going to go to the doctor in a few weeks. Check adequacy of their self-care behaviors. Do they shower? Do they clean? Do they clean themselves appropriately? I'll tell you right now, the first time you assess someone who hasn't been taking care of themselves appropriately, it'll be very evident when you walk into the room. They usually have an odor, and it could be a gender issue. It could be a political, it could be a cultural, it could be so many different things, but you'll be able to assess that. And you may need to do some education about how to care for themselves, but you need to find out what's going on. Why is it important to check input and not just output? Give me some things you'd worry about why we don't just say, oh, what's your output? I don't care about the input. I want to know both input and output. Why? Dehydration, that's always a good one to think about. Hydration status, yes. Yes, good, Jennifer. That's very good. We need them to be equal. Know the balance, how fast regulates bladder retention. If I take in 2 liters of fluid in a day, my body should be able to use it and get rid of about 2 liters a day. They should equal out. Okay. Anything major with loss would be going through the stool. So when we're talking about fluid levels and retention, our kidneys keep everything in homeostasis or equal. So that's what we want to do. Absolutely. Some things you'd worry about is congestive heart failure, which you haven't studied that yet, but the idea of having too much fluid, if we take in fluid and we take in 2,000 milliliters, and we only get 900 out in 24 hours, I'm worried because that patient's holding fluid at that point. Somebody who's diaphoretic or sweating, they're sweating heavily. I need to make sure that what's coming out is matching because they're also sweating. So I may expect it to be a little bit less if they're heavily. Kidney failure, if somebody's kidneys aren't working, I can tell pretty quickly that the urinary output is not measuring the intake. So good, some things to think about. We need to know how much you went in to expect out. Yes, absolutely. Physical assessment. I've already talked to you about the CVA tenderness. Urinary bladder, being able to palpate it. You cannot palpate an empty bladder. You can palpate a full bladder or even half full. You'll be able to kind of feel that. Percussion, you get a cool little sound when you do that. It is a lost art, but it's something that you need to know how to do. Bedside scanners can show you exactly how much urine's in there. Urethral meatus, look at it. Tell me if it's red, if there's any drainage on it. Skin, color, turgor, texture, excretion of wastes are in that area. So we want to make sure it's clean so we don't have skin breakdown. And then, of course, assess the urine itself. Clear, cloudy, red, blue. Are there fat deposits in it? Yes, you can see fat deposits in it. You can see crystallizations forming. You may not know what it is yet, but you need to know what to look at and what you see. Again, you may not know what it is, but you may need to know when to call somebody. If somebody has yellow urine, all of a sudden they're like, oh my gosh, they call you in and they are frank red bleeding as they're trying to go to the bathroom. Are you worried? Is it different? That's what you catch. That's what you catch. That's a quick, broad one, but that's what you caught. Something could be happening and you'd call for help. Measuring the output. You can ask them to go into a urinal, a bedpan, a specimen container, anything, and then there's measuring devices to help you with that, especially those specimen containers. Measuring urinary devices, the urine in the actual devices, because they have measuring things there. Don't just say, well, don't measure it out of a Foley bag when we're talking about certain things, especially when we're talking about getting a sample. You're not doing that out of the bag. Because when you get the sample out of that Foley, it's been sitting there in a stasis form. So the levels are off. They're not exactly where they need to be. We want a fresh sample when we're taking that. But with the urinary output, we want to try and empty that and measure that in an actual graduated cylinder. Flat surface at eye level, you read that just like cooking. Note amount of urine voided and record any information. What it looks like, does it have a stench or anything like that. Discard urine in the toilet as necessary. Freshly voided specimens. So these are the types of urine collection. We've got fresh. So with this kind of stuff, you collect it as from the patient, you label it appropriately, and you transport it to the lab as soon as possible. You may need to refrigerate it depending on what you need. You need a clean catch urine. This is different. You need to know how to educate a patient about this, where you have them cleanse their genitalia, they begin to micturate, and then midstream, they catch it. And then again, clean their genitalia afterwards. You're not catching the first little bit that comes out because there's usually extra bacteria at the tip of the urethra that you don't want to catch. You want midstream. Sterile urine specimen. How do you get a sterile urine specimen? Straight cath. Absolutely. Cath them. Absolutely. What if they already have a Foley in? Pull from tubing. Absolutely. Clamp it. You're going to clamp the hose. Good. You guys talked about this stuff. But you're going to clamp the hose. Make sure that you've got a urine in there. Don't wait too long because you don't want the bladder to back up. And you pull from tubing. Usually a few minutes is enough to get it out of this. But clamp it and pull it from the tubing. Don't get it from the bag. It's never pulled from the bag. Hey, don't pull it from the bag. 24-hour urine collection. I know so many new grads who've done this wrong and have to start over. And if you start over, you're going to make the patient mad, the urologist mad. This is a very specific order. Make sure you know your policies, but I'm going to tell you your book's way. It's very similar to most hospitals. You're going to have the patient void into the toilet and dump it. That does not count. That is the very first set of 24 hours. They empty their first void. It doesn't count. After that, this big orange area is usually what these look like. It's a collection tube. You collect it every time they void, okay? And then that container is put into an ice bath at the side of the bed. And that ice is kept up for the 24 hours, so it's kept cool. Because otherwise you'll have things that'll break down and metabolites and the numbers will be wrong. You need all the urine past that first void for 24 hours. You need to educate the patient. You need to educate your aides, educate yourself, educate the LPNs. Do not dump that urine. If that urine is dumped, guess what? You're starting over the 24-hour count. If the patient forgot and went to the bathroom and said, oh, I'll do the next one, you're starting over the 24-hour count because these rates are very, very specific. And these labs and this urine is very, very specific. Put up signs by the bedside and by the toilet, on top of the toilet. Just things so people would normally have to move to really think about it. Don't let them get rid of that urine for 24 hours. Do not discard it. If they miss one, it's done and they must restart the 24-hour, including the first void. Don't forget how to do a 24-hour collection. You've got a lot of different tests that you can do. You can do your routine urinalysis and general lab, telling you pH, blood, urine, what's in the urine. Is there blood? Is there sugar? Is there protein? Dipstick testing, which you can see there, bedside for more glucose and ketones, blood and protein, more specifics. You can do blood studies, which check things. Now, very important labs to know for your kidneys: BUN, creatinine, and GFR. BUN stands for blood urea nitrogen, which your normal value is 10 to 20. 10 to 20. BUN is a byproduct of ammonia after liver transforms urea, okay? Into urea, excuse me. Ammonia is bad. We start losing our consciousness levels pretty quickly when we have ammonia in there. So our body very, very rapidly changes it into BUN, which is for urea, specifically blood urea nitrogen. BUN is the water-soluble version of ammonia. Our liver specifically, will quickly take that, allow it back into the bloodstream until it gets to the kidneys, and our kidneys will say, hey, look at this water-soluble, get it out. It will recognize it, it will pull it, and it will leave the body. It will not be reabsorbed. Creatinine is 0.6 to 1.2 is your normal labs. This is just a general waste product of muscle metabolism. People who are heavy weightlifters, you usually see this slightly elevated. If their kidney function is low, you'll also see this become elevated because the creatinine isn't being removed from the body because the kidney can't handle it. The kidney can't catch it. Glomerular filtration rate. Remember we talked about the glomerulus and the Bowman's capsule. It's literally talking about the flow rate of filtration through the glomerulus. This is above 90 or above is how you would see this. These numbers are from your book. You may see slight differences in different hospitals. These are from your book. Some other ones that you might want to add to this slide to help you study. Specific gravity, 1.002 to 1.030. So, did you have a question about those? Do you want me to give the numbers again? One more time. Okay, BUN, 10 to 20. Creatinine is 0.6 to 1.2. GFR is 90 or above. And specific gravity is 1.002 to 1.030. Let's do a clicker check and then take a break. 24-hour urine collection and process for a client. The nursing assistant inadvertently empties one specimen into the toilet instead of the hat. The nurse should what? Yes. Don't forget it. This is one of those things you just don't forget. Just like you're 30 or above, you need a minimum of 30 for a urinary output per hour. You never forget that. It's on your NCLEX as that. It's there forever. Do not empty a 24-hour urine in the middle of the 24. You bring it appropriately. They have to void the first. They have to void first, and then they hold it for 24 hours in an ice bed. Good, good, good. Pause. Okay. This is just a slideshow of things that you've seen or will see in lab and clinical. You've got catheters on here. You've got hats or collecting cups. You've got your graduated cylinders. You've got your Foley bags, leg bags, urinal, fracture pans, bed pans. These are just kind of there for you to see. These are all devices. They can spill. They can break. They can become occluded. Assess your equipment before you use it, and at all times while taking care of your patient. Especially like a Foley tubing. It's very easy for somebody to roll over and kink it. So before you start going to emergency or you're like, oh, this patient stopped urinating for, I haven't seen any urinary output in like 2 hours, so it's less than 30. See if they're laying on it or if it's kinked. Make sure it's anchored appropriately because maybe it's pulled and they've turned a little bit and it stopped pulling, but it's kinked the tubing. Is it broken? Is it clamped? Did somebody clamp it and forget to unclamp it? Is it folded on itself? A urine specimen from a patient with an indwelling catheter should be obtained from the collection receptacle. True or false? Good. False, false, false. False, false. No, yes, good. You do not use that. Nursing diagnoses. You guys have practiced this a lot at this point, so you should have ideas of what this stuff means. Urinary function as the problem. So, incontinence. What does incontinence mean? No control or loss of control, no sensation, not necessarily full loss of it. There's different types of incontinence, but a loss of temporary or permanent control of that ability to micturate or void. We have pattern alteration. Maybe they've gone from days to nights, or they have something where they've been going to the bathroom every time, then all of a sudden they don't go in the mornings, or they haven't gone in a while, and they notice the difference in their pattern. Urinary retention. Again, men very big on this one with BPH. You worry about the urine staying in there and being unable to void, increasing those risks of UTIs. Anxiety. Again, someone who's constantly anxious decreases ability to void and urinary output. Caregiver role strain. Why would that be a nursing diagnosis for somebody with urinary function as a problem? What's the problem? Why would we have caregiver role strain? Anxiety about what? Well, you can't answer caregiver role strain by saying caregiver stress. Keep them dry. Yes, there we go. Keep them dry. Unable to ambulate from the bathroom. Yes, this patient may need help. Taking care of someone else in general is stressful. But now you may not be comfortable taking them to the bathroom. You may not be comfortable wiping them. They may say they need to go to the bathroom, and you feel constant like you need to help them with things, and you spill something. You have to change the bed, especially for people who aren't nurses. You need to change the bed. You need to take care of the patient. You need to make sure they don't break down, but you forgot it one time. Now they have skin breakdown because you made a mistake. It can add up very quickly, which adds into the anxiety of the caregiver. Absolutely. Now they have nursing diagnosis that we have on top of it. Very good. Risk for infection. We've talked about that. All right. Planning for patient goals. What's a great urinary output specific number that we want for patient goals? At least 30, 50 to 60 is a great goal, though. Absolutely, yes. If you had to choose one or the other, your bare minimum is 30. Remember that, because if we want, I want 50 to 60, but if it's not on one of my questions or one of my patient's abilities, that may not be an option. So think minimum 30. 50 to 60 is where we want it to be. All right, so we want them to be able to produce a sufficient quantity. Thus, we did that. Empty bladder completely at regular intervals without discomfort. Provide care for diversions and know when to notify the provider. When is it not working? When is it not emptying? And customize these to your patient and their current situation. You don't choose urinary diversion if the patient can walk to the bathroom and they're going through their own urethra. And then unhealthy urinary patterns. You may have to educate them on the proper way. It just really depends. Is it front to back or back to front when we're wiping? Front to back. They may be doing it wrong, especially if high-risk UTIs, they constantly get them, and then they find out it's E. coli a lot. You may need to educate them. Hey, can you tell me the way that you take care of yourself? Again, you need to be very careful with things, and you need to be very sensitive with it. But tell me how you use the restroom and how you care for yourself so I can make sure you're doing everything appropriately. And even if you don't feel comfortable with that, you need to get comfortable with that. But you can just start teaching them and say, hey, I need to educate you on these things because of your UTIs. We tell it to everyone with UTIs, and here's how you do it appropriately. Older patients sometimes do back to front. Again, you've got to educate them. Okay, promoting normal urination. You want to maintain voiding habits. Have them use the restroom, sit appropriately, and do what's working for them. Promote fluid intake. Box 28-3, page 721. These are some things to help you make sure. And some examples of this stuff is make sure the water is within reach. Remind them to drink. Have you had enough to drink today? Have you had some water today? Have you drank some from your cup? If they need more water, you can help with soup. Soup is fluid-based and helps with that watery foods. Foods like watermelon, high water content. They like it, and it gets them what they need for fluids. Sometimes they can use a straw to help to yank it down. It's easier for some people to drink chilled drinks versus warm. Sometimes you may have to help with mouth care, provide them privacy so they have time to actually urinate without you standing over them, because I'm not going to want you holding my shoulder while I'm trying to go if I can do it on my own. Give them privacy if you can, as much privacy as possible. Sometimes that means you have to have the foot in the bathroom for a fall risk patient, but you educate them why, and you turn your head and give them as much space as possible. Assist them with toileting. Some patients can't make it to the bathroom. So how would I help a man or a male with that genitalia? How would I help them go to the bathroom if they were in bed and couldn't make it to the bathroom? Give them a urinal. Okay, what else? Hold the urinal. Sometimes you may have to hold the urinal. Yes. Place urinal, cover with sheet, close curtain or door, get urinal. Yes, very good. Could I stand next to them, hold them, and have them stand and use the restroom? Would that be easier? Yes, you could. Absolutely. That may be easier for a male to be able to handle. You're just kind of there balancing him, depending on the issue. If he can stand, he may really want to stand and urinate. He can't make it to the bathroom, but you can help him by being there and helping him balance. And some men can absolutely not pee laying down. So that's why we try and stand. What about with women? How would we get a woman to help them actually micturate? Bedside commode, okay. Bedpan, good. Pure wick, Bedside commode, bedpan, PureWick we have as well. But if, PureWick is more for like leaking, etc. If somebody can sense that they need to go, get them on a bedpan, allow them to keep that normal ability to go. PureWicks are nice, but if somebody has the ability to tell you they need to go, you can help them by using a bedpan or bedside commode. Good. Okay, maintaining normal voiding habits. We want to keep them on a schedule. Sometimes we have to teach that schedule to them every 2 hours, as long as that patient's awake. Try and get them to the bathroom. If they have an urge to void, help them to the bathroom when that urge occurs. Give them privacy, give them the proper positioning, and have that urinary out or that hygiene. When you're taking care of somebody post-op, you would normally expect to see a decrease in urinary output. Again, we've talked about anesthesia. What do you think the minimum urinary output is for that patient now? We're in anesthetics. Yup, 30. I don't care. It's still 30 because your kidneys may be under anesthesia, but they still need blood flow, so they're not damaged. So your base is still 30 there. You want those kidneys perfused. Diuretics, which we get to talk about in just a few weeks. I'm excited for, but these are ideas for this, okay? They prevent reabsorption of water and electrolytes. We have thiazides and potassium-sparing diuretics. We have all these different classes, loop-acting. The kidneys need to be working for these diuretics to work, though. If they work on the kidneys need to be able to respond. Cholinergics will stimulate contraction, producing urination. Analgesics like pyridium help with UTI burning sensation. Doesn't cure it, but it helps with the sensation and symptoms. Tranquilizers will suppress the CNS, which diminishes the effectiveness of that reflex for urination, making it more difficult. So they may not feel that need to go. I had to make sure. Some other things just to kind of have in your head. There's a lot of side effects that I've talked to you guys about multiple times, but here's some new ones for your kidneys. Antihistamines cause retention. Tricyclic antidepressants cause retention. Antispasmodics, antiparkinsons, beta-adrenergics, all can cause urinary retention. Benadryl, Allegra, stuff like that, all can cause it. Levodopa, Bentyl, all can cause retention. Increasing your risk of what? If I have your retention, what do I have an increased risk of? UTI. Good, good. Connecting the dots. Kidneys are amazing, aren't they? They're better than any other system. I want to hear that. I want to see that. Medications that affect color. This is really interesting, especially if you go into the ER or if you go into the ICU, you're going to see some really cool stuff. Anticoagulants can cause your urine to be red. You lose a little bit of blood with that, but there are some other color changes that occur. Diuretics, pale yellow, pyridium, orange to orange red, Elavil, blue, green, levodopa. Why is this important for you to know this? Charting, okay. There you go. Assess correctly, med versus pathological. No one to be concerned. Don't freak out. Absolutely. There you go. You see a patient on pyridium, you give it to them, and then you see red coming out of their urethra, but it's like a clear red. It's orange red. They don't like Tennessee football that much. That is a side effect that you would expect with this medicine. So you'd educate your patient before you give this medicine. Hey, just so you know, you may see orange, red urine when you take this medicine. That is normal. Don't freak out about it. You don't need to press the call light 9 times to get me in here for that. Where we're dealing with, levodopa, that patient may not be talking to you at that time, but you see brown, black urine coming out. They're on levodopa. You'd expect it. I don't need to call a rapid or a code, anything to happen. I expect that stuff to happen with this. Absolutely. Good, good, good. All right, incontinence, we've talked about managing and preventing breakdown, assess your patient, check for patient changes, clean their linens if they do have a mistake. There's incontinence alarms that you can actually get. This happens more in children's, but they do have it in some hospitals as well, where if they do become incontinent, an alarm will go off to tell the nurse and to change that patient. We want to stop breakdown. Encourage lifestyle modifications. Maybe we need to teach them about briefs and how it's going to help them. Implement bladder training being where every 2 hours they just go to the bathroom and try and go so their body gets used to it again. Things like Kegels. How do you tell a patient to Kegel? I was told this by a urologist, but I've told every patient, every student this, and it's helped every patient I've told who doesn't know. Start and stop flow, okay? Pretend to hold your urine, okay? That's a good one. Hold like you're stopping urine flow. Those are very easy ones to do. A urologist said that works. But there's one more thing you can tell them, which actually activates everything. Tightening the pelvic floor muscle, then release. That's us. That is telling us what to do. That's not telling, like, that is not educating somebody on a 4th grade or lower level. Pick up a marble with your butt. The urologist told me that. I've tried to do the hold your pee. Some people don't get it. When you tell them, try and pick up a marble with your butt, they got it. They're like, oh, and they start practicing it, and they're like, wow, that helps. Something to think about. Now, $100 bill between, well, that works too, trying to hold a $100 bill, but I mean, marbles. So looking for a marble, please don't. Something to think about. Again, tell them to hold the urine. That's a very useful one, but some people have a hard time understanding what you mean when they kind of get, they do a little bit of it. Do it. Okay. We have the anti-incontinence devices like incontinence pads as well. Okay, urinary incontinence some more. We want them to be as independent as possible when we're taking care of these patients. As we get to them and they're able to help, if you can give them the urinal to help with that, that's great. Maybe they'll be able to, help you out and help themselves out more, because I want them to walk out of here being able to care for themselves. We have medications that we can help with that, which you'll learn about. Surgical interventions. We can create a pouch if their bladder is not working appropriately or has cancer or anything. We actually create a pouch that we can create in their chest that they palpate and push down on, creating something that they can empty out of, or they can cath themselves through it. And then educate them about that. Now, parental teaching, again, you're going to have a lot of this in pediatrics, but one of the big things to teach about Aneurysis with them is don't scold a child if they've had it. They may not be able to control it, or they may be having, symptoms of night terrors that make it more difficult. Use of products that are absorbent. You want functional disability of the patient, type and severity of incontinence. So do they need a small pad or a big pad? Some hospitals have different sizes. If a patient's call light goes off, answer it. See what they need. Gender. Could we use briefs, condom caths? Is there caregivers available to help to make sure those absorbent products are being placed when they're at home? Have they tried other things? They may need pads to ensure skin protection to make sure that anything that they're doing at home is taken care of so they don't have that skin breakdown. What does the patient prefer? Would they rather wear briefs than have an incontinence pad, or vice versa? Would they rather have a condom cath while they're in the hospital, and because normally they don't wear briefs, they lay in bed and don't use them? The word is not adult diaper. The word is brief. Brief, brief, brief. We do not say diaper. Some reasons for cath. Relieving urinary retention. We need a sterile urine. We need a urine specimen. Emptying bladder before or after surgery. Monitor ill. And then before I talk about the bottom one, what do you not see here for reasons for catheterization? Tell me some reasons you wouldn't catheterize a patient. Lazy cath, absolutely. UTI, oh yeah, please don't. BPH, we can do a BPH, it just depends. We have specific ones for that, but yeah, BPH isn't there. Let me ask it this way. The patient comes to you and he's incontinent. Good. The patient comes to you and he's incontinent. Do you cath them? No. Just because they're incontinent doesn't mean you cath them. Now, you may be able to put something like a condom cath on there or a PureWick to help out, but you do not put a full-on Foley catheter just because they're incontinent. It would be easier if they drained it. That's nice. We're not here to make it easier. We're here to care for the patient. You're going to cause an issue. Yeah, bladder scan to see if it's due to overflow, which has specific rules for it. And also, again, the big things is just because they're incontinent doesn't mean you cath them. Just because it'd be easier on you if they were catheterized doesn't make it easier. Doesn't make it that you do it. You need provider order for a condom, cath, briefs, pure wick, etc. Depends on your place of work. Condom cath usually yes, briefs usually no. Pure wick usually it depends. So teaching them clean and sterile techniques so they can, some people have to be able to cath themselves, so you may have to educate them. So what is the difference between clean and sterile technique? Hygiene, yes, gloves in sterile area. Yes, good, gloves. So you've gotten the general idea. One is clean, one is sterile. Yes, thank you. One is clean and one is sterile, the difference between clean and sterile. Types of gloves, yes. So preparing the area and taking care of it. The big thing is also when you're teaching, a clean insertion is done by the patient normally, because it's very difficult for a patient to stay sterile when they're doing a self-catheterization. Sterile technique is usually done by the nurse, but again, you can teach that depending on how they're supposed to do that and if there's like a stoma or like an opening that they need to access. Clean insertion, yeah, is done by the patient. Good. All right, urinary catheterization. Introduction of a sterile tube into the bladder. If it's sterile, what technique are you going to use it? Sterile technique, thank you, absolutely. We've got straight caths, we've got Foley indwellings, and we've got suprapubics. You can get your samples sterilely. You also have one more on here that I want to talk to you about, but just so you know, suprapubic is a surgery that they actually go in and above the pubic bone, they actually place one through the abdominal wall. The Kuday catheter is something you need to know about. Special hard tip version of these types of catheters to help bypass enlarged areas. This is something that's a little bit more firm at the tip. Sometimes someone with BPH may need that, but positioning is very important to know male versus female when you're doing this. With a male, they are laying supine to actually be able to put this in appropriately. Can you tell me the two positions a female can be in? Supine, S-U-P-I-N-E. Oh, Kuday, C-O-U-D-E, with the little thing above the E. I always forget that. So dorsal recumbent is how a female, yep, there's one. Dorsal recumbent and sim sideline. Those are the two positions a female can be in for catheterization. Here's an image of your suprapubic. Again, it is a surgical placement. Clicker check. 4 nurses are inserting catheters in their clients. Which nurse statement related to the intervention is incorrect? Remember your key words. We're looking for a wrong statement here. I am inserting this catheter to you guys are getting it. B, treat your problem. I don't care. Just because they have leaking urine doesn't mean they get a sterile Foley. Good. For managing urinary retention, we want to prevent, so for nursing care for preventing urinary tract infections. So we want to keep it clean, catheter care, sterile technique for placement, and clean technique for cleaning. How do I prevent backflow of urine when somebody has a catheter in place? Balloon helps. Empty the bag, use gravity below the bladder. Okay? Always keep the Foley bag below the level of the bladder. And you will see that sometimes where you have to quickly fix it because some people will just throw it on the bed and do it, and that's fine if the bed's slightly elevated so the bag is still below the level of the bladder. Check for kinks, absolutely. Encourage fluids, make sure IV and PO, so they have that fluid going. And you want perineal hygiene, help with perineal care in general. So you have a patient who says, hey, I haven't been able to go to the bathroom. I've got a Foley in place. I've been going. And all of a sudden, I haven't seen the urine. I feel like I have to go. Like my belly's getting a little bit bigger. What are you going to do first? Check your tubing. Good. Check for kinks. Check for kinks. The next thing you can do after you've checked for kinks, it's not there, is you can actually irrigate the catheter. A lot of catheters have the ability to actually irrigate it, push fluid through, see if there's some sort of occlusion. Usually have like a normal saline flush to do that, especially if there's a sudden decrease in output. Usually a small occlusion has occurred if that happens. It's not common, but you want to make sure that there's not an occlusion because, again, you don't want it to block. Now, let's say you're taking care of a patient from a nursing home. You're in the hospital, you get this patient, they've had a Foley for years. You take a look at the Foley and you see skin growing over the Foley. You see redness around the urethra. You see sediment and nasty color. That specific gravity is probably 2. And you're like, I don't understand this stuff. What do you want to do with that? Curse at the nursing home. Okay, that may be something you do. But what do you want to do for the patient? Change it. It's time for a new Foley at that point. Remove, clean the patient, and give them a brand new Foley catheter. Take care of it. Foley care is not going to do enough. You need to change everything. That Foley needs to be out. I don't even know if that balloon's working at that point. I want everything out, and I want to clean everything and put a brand new one into it. For the changing, again, depends on the policy. Certain Foleys can actually go longer than 15 days. Depends on the policy and the manufacturer on the actual one. Some of them actually can last 60 days or longer based on what it is. Yeah, and yes, you can wait. Yeah, it would absolutely be okay to wait some time to get for that irritation to go down. But it does depend. You have to clean everything up and kind of assess it. You may need to call the provider and let them know, hey, I'd like to not put this Foley back in for a little bit. I'll clean them up and put a pad down for a little while. Are you okay if I don't put that back in? Because you may have an order like they're being admitted for a new Foley. So that's okay. What about also doing a culture if it gets to that point? If it gets to that point, yeah, if they have a UTI, you're going to get a culture on there. The problem is we are going to have a lot of old urine there, so we're going to have to very specifically, clean everything, get some new urine out of the bladder, and get a culture. Absolutely. Good questions. Good questions. Educating about a urinary diversion. Urinary diversion, just another way to get urine out of there. Tell them why you're doing it and the rationale for treatment. Is the bladder removed or is the bladder being bypassed? Has there been trauma or cancer? Is there some sort of disease where they have to have this diversion to allow it to heal? Self-care behaviors. Again, tell them about it. Do they need to be able to touch? They do need to be able to touch and care for anything that's not there, that's not been normally there. So if they have a diversion, a conduit, something like that, you need to know before that they leave your care that they're able to touch it and care for it and take care of it because it's part of them. And if they can't, you need to try and stop them from being actually discharged because they're going to walk out with this diversion not knowing and refusing to care for it, and they're going to come right back because things are going to start breaking down and they're going to have a major problem or worse. That's what emergent surgery. You need follow-up care, supportive resources. There's actually hospitals to help with this. There's a place in Knoxville called Pouch Place, which mostly deals with stomas. We're talking about the GI tract, but they can also help with ileal conduits as well. The hospital has educators to help with it. We want them to talk to us. We want them to tell us what they're afraid of when they leave with these diversions. Tell us what's going on so we can help them. It's a new portion outside of the body. It's a stoma or an abnormal opening. It's a pouch. We want them to be able to care for it. So being able to verbalize fears is the first step to help them get over them. So tell me how you're feeling. Tell me what's going on. How do you feel about this? Let me watch you take care of this. I'm going to show you once how to do this, and then you're going to do it every time I'm in here while I'm watching, so I can make sure you know how to do it appropriately. And we want them to demonstrate a positive body image. We want them to accept it as who they are. If you ever look at Instagram or anything like that, you can actually look up ileal conduit body image. You can look up stoma body image. And there's plenty of people who, even on Etsy though, you can actually find pouches, carriers to make it more stylish. There's some very interesting things they can do that is becoming part of a normal life for a lot of people. And people recognize that now. So they need to accept it as part of who they are. Right? It's just a change to what's going on and what they're going to be doing from now on. I took care of a patient with urostomy, and this patient did not provide appropriate care. The skin around it was extremely raw and looked awful. Yes, very easy to do if not taken care of. All right, types of urinary diversions. You've got urostomy, surgical opening for urine elimination. Look, it's ostomy. So you've got stoma, which is just a hole that goes outside the body. This is a definition slide. Cutaneous uterostomy, rerouting of the ureters to the surface of the abdomen, which I'll show you some pictures here. Ileal conduit, removal of a portion of the ileum with nerve and blood supply taken to the abdominal wall with the stoma, very common. And then you've got your conduit, your ileal, which is the cock pouch, which creates a false bladder that needs to be capped and manually pressurized to be allowed to empty. There's your stoma and cock pouch there. You get an idea of how that works. There's your ileal conduit picture to give you an idea of what's going on. Talking about it is nothing. It's seeing the images will help you get an idea of how you'll be talking to them and what's going to be happening. Give them privacy as much as possible when you're trying to help them urinate. Assist them to position like we've talked about. Get them that normal routine, after meals, prior to beds, at night, hour of sleep, every 2 hours if you're training. Promote adequate fluids and nutrition. Make sure they have the adequate intake for proper output. And assist with hygiene like perineal care. Before I ask questions, I want to talk about a couple different things. Urinary incontinence. We want to teach them about that. If they are incontinent, we want them to avoid dehydration. What are some things we want them to avoid? Something that would increase urinary output. Caffeine, alcohol. What else? I've seen 2. Chocolate, good. Salt can change it. Chocolate's big. Some other thing, diuretics. Well, it's a medicine, so we have to be careful with that. So we have to be something to worry about. Spicy food. Some other things that you want to know about, more interesting to educate them on. Artificial sweeteners. Ibuprofen. Thank you. Artificial sweeteners actually increases your urinary output. Spicy foods and citrus as well. These all irritate the bladder. By irritating the bladder, you make it more likely to squeeze and make you want to go to the bathroom. What does constipation have to do with, juices? So citrus in general, juices, fruits, anything like that. What does constipation do when we're talking about incontinence? It pushes on the bladder. It constricts the urethra. Good. These things all make it harder or make you have more of a sensation to need to go or harder to actually go. Yes, it can block. Pressure in the urinary tract interfering with flow and can make you want to go if it's pushing on the bladder. Exercise, low impact, can help with the control. Losing weight can help. So you have less adipose pushing on that bladder and urethra. Smoking. Smoking needs to be stopped by every patient that you have. Don't smoke. You're going to have this in every single disease process or every system as you go through this program. But don't have them stop smoking anything, because smoking in general increases the risk of any type of cancer, including bladder cancer. Bladder cancer has an increased risk with smoking, vasoconstriction, decreased blood flow. Nicotine causes stress urinary incontinence. So you have an increased risk of cancer and you're going to pee on yourself. When is the best time to take something to make you pee? Morning or evening? and why? Pee all day. Yes. Doesn't interfere with sleep. Good. Won't keep you up. So you're awake. Don't wake up. Good. You take your diuretics. You give your diuretics in the mornings. So that way you have the day to pee, and that you're not getting up every evening, 3, 4, 5, 6 times a night to pee. Don't do that to your patients. Now, questions? Eight cups a day. The soups, popsicles, water can count towards it. They do. That fluid intake does technically count towards that.